All right, everybody. Thank you so much for those of you that are hanging out in the chat and sticking around with us. I know some of you have been here for a few hours already, and then some of you have been here for a few days straight. So much appreciate all of you. But tonight, here we have Dr. Ben, who's a good friend of mine, and I cannot wait to hear him speak about the common misconceptions related to abortion, right? And the things that people believe about abortion. Does that sound like
Yeah.
okay, perfect. I was gonna say, did I get that right? Okay, perfect.
Yeah.
Um,
Yeah.
and now you're on a number of shows and channels.
Mhm.
Talk Heathen is one of them. You have a lot of experience speaking to people, but one of my favorite things about you, just kind of as a creator, is you have the presence of the performer and then you have the knowledge of the doctor, which I feel like in at least in our sphere is like a 1-2 punch. You know, you've either got the entertainment value, but people don't have necessarily certification, or they have all the certification, but they talk like a TED Talk 24/7. But enough for me. Welcome, Dr. Ben.
Yeah, thanks for having me. I'm super excited. I know I kind of like pressured everybody into letting me do this talk because it's one that people don't
It's
often
important.
like to talk about. It's a very important topic, but it's a very serious topic and a very emotional topic. And a lot of people get very tense, especially with this, because I think for a couple of reasons. Number one, it is a very heated discussion, and people have a lot of trauma associated, especially if anybody has experienced an abortion or if they've had a particularly traumatic childbirth, or even people that have experienced miscarriage. It can
Right.
be a very polarizing and heated topic,
Yeah.
but also people, I think, are hesitant to engage in this because of how sticky it can be as an argument. And it's kind of hard for people to know where to go with this discussion and how do we engage in this topic in a productive way while still, being aware of everything happening and being aware of the logical tactics that are happening from both sides of the equation.
Right.
And I feel like a lot of people engage with this from a kind of a few different viewpoints. There's like a primarily political viewpoint, there's a primarily philosophical viewpoint, and primarily like a religious viewpoint. And I think not a lot of us are as familiar with the scientific viewpoint, which, as we kind of talked about before the show, is really important because we're using any of these discussion tactics to try to regulate a medical procedure. So
Right.
it's funny that we have a lot of people speaking about a medical procedure without really any knowledge of pregnancy or how to
Right.
manage a pregnancy.
Yes.
And so that's kind of why we're doing this tonight, is to kind of set um, kind of some guidelines for abortion, give everybody kind of the tools from ACOG themselves, the American College of Obstetrics and Gynecology. So, like the top experts in this area who set the guidelines that physicians follow, and also to kind of help you not only understand this but use it in a discussion and figure out, how do I engage with somebody? Where is our point of misunderstanding, if there is any, and really what is the heart of this issue? Why are we having conflict?
Right. Right. That must be such a frustrating place to work too, because I imagine even the people who work there get encountered with people who are like, nah, man, I'm still going to believe the Netflix thing I saw or the Fox News thing I saw, when they're speaking to people whose job it is to literally regulate these things. Um,
Yeah.
so kudos to them.
Yeah, and something big here. So kind of the first place I want to go with this is kind of establish some definitions. And I actually
Perfect.
do want to pull up a picture, which hopefully it's going to take a second to open, but hopefully it will.
It might make me let it in or something.
Yeah, sometimes my computer is weird about like hiding the image. But here's the little timeline just to give a rough idea for pregnancy. And these are kind of these new gestational age boundaries, if you will. In the past, they kind of use different terminology, but this is kind of what we agree on now. So when we talk about any different point in a pregnancy, uh, we're referring to the weeks of pregnancy with regard to gestational age for an estimated kind of date of conception. So we have this kind of divided up. So a lot of us know that 40 weeks is kind of like the ideal spot for a full term baby. Kind of beyond that, we get into like 40, anywhere between 39 and 41 weeks is considered like full term. Anything beyond 41 is late term. Anything between 37 and 41 is like technically term. Like all of that from early term, from 37 to 39, and full term 39 to 41, all of that is a term pregnancy.
When a baby is preterm, what's usually the main issue you run into? Like, what's the last thing to develop that makes it dangerous to be preterm?
um so that's a tricky question to answer. um
Or could it be just a wide variety of things?
yeah, so it's a wide variety of things because you have like you have cardiac function, you have lung function. Mostly, usually the biggest thing is lung function.
Got it.
Getting that to develop earlier, because you need to produce enough surfactant to um, overcome the uh, like the surface tension of fluid. You have a lot of that
Yeah,
in the lungs. So
got it.
you need surfactant in order to overcome that surface tension and open the lungs. So that's oftentimes when you see a newborn preterm baby. Oftentimes they're in the NICU on oxygen or
Yeah,
on a CPAP because their lungs can't really function. The other thing too is kind of um, more probably related to the placenta and its function
got
and the
it.
baby's ability to kind of perfuse itself. Um, so, yeah, kind of looking at the preterm side of things, from 34 to 36 weeks and 7 days is preterm. Um, and this is kind of where we've established is you have pretty decent viability, but it's still, despite saying that, that's still not super great. So
Right.
this, a lot of people view viability as like this goalpost of like you are either going to survive or you're not, and at this point exactly is when we're going to make that determination. Well, it's all going to be risk and likelihood of survival. So the closer you get to full term, the greater likelihood you're going to have a surviving fetus with minimal complications. The earlier you go, you're opening up more risk for those complications and for mortality. So when I say that a fetus is viable, that doesn't mean that they'd have good survival outside of the uterus.
They're like a
Um,
C or a D. They're not failing, but that's not necessarily where you want to aim.
right, right. So when we start getting into the definitions here, we're going to discuss a lot kind of between this very sticky period of 20 weeks to 34. And that's even before preterm. In kind of this, it's technically viable, but not likely to survive area. So now that you've kind of seen the trajectory of a pregnancy, I'm going to define kind of our terms for you. So when we talk about abortion colloquially, it has kind of a nebulous definition because a lot of parties use it in different ways. So um, commonly, you'll see the pro-life movement using the term abortion to mean the killing of a fetus or the killing of a
Right.
baby.
Right.
Um, when maybe a lot of pro-choice leaning people will use the term to mean the either medical or surgical removal of a fetus from the uterus, which is closer, but still not entirely accurate. So the way that ACOG delineates this is kind of related to that gestational timeline that we just looked at. So if we kind of use 20 weeks, even though viability is still very poor, it's at least not like close to zero. So
Mm.
kind of before 20 weeks, you're pretty much guaranteed to not survive outside of the uterus.
Wow.
20 weeks and beyond, and even closer to 24 weeks and beyond, your chances are much, much higher and definitely not zero. So that's kind of the point that we use to determine what is an abortion and what isn't. So an abortion, by definition, is the either the spontaneous or non-spontaneous ending of pregnancy before 20 weeks of gestation. So any ending of pregnancy before 20 weeks is an abortion. So that includes induced abortions medically. This can be surgical abortions before 20 weeks. This can also be spontaneous miscarriages. So those are also qualified as abortion because it is before that 20-week mark.
What about and maybe it's not because they wouldn't survive, but I've heard the argument online that even giving birth to a live baby, if it's before a certain point, because they're being surgically removed, counts as an abortion. Is it only
So
that way if they don't survive?
So we'll get to that. So if it's
Okay,
before 20 weeks, it is an abortion.
got it.
If it's after 20 weeks, we don't use the term abortion necessarily, but it will fall into, let's say this is or it is spontaneous, a spontaneous ending a pregnancy after 20 weeks. So it happens naturally without medical intervention is a delivery by definition.
Got it.
Um, but also the non-spontaneous ending a pregnancy after 20 weeks is also a delivery, but both of these now are qualified, or not both of them, just the non-spontaneous ending a pregnancy after 20 weeks is a termination. But also the non-spontaneous ending a pregnancy before 20 weeks is a termination. So kind of clearing that up a little bit because these could be very, very muddy. So the non-spontaneous, so medically or surgically induced terminations, using the term, ending a pregnancy before or after 20 weeks, so at any stage of the pregnancy, if it is non-spontaneous, it is a termination. No matter what happens to the fetus, whether it lives or not, this is a termination. Um,
Interesting.
so you have your if you have a little grid, you have spontaneous on one side, non-spontaneous, and then you have before 20 weeks and after 20 weeks. And you can kind of divide the definitions up in that way. So this is where it gets interesting because I hear a lot of times people saying things about having an abortion in the second trimester. Well, by definition, you can't. And
Right.
it's important to know that a colloquial definition isn't necessarily wrong. Like there's the whole point of a definition is to mutually understand each other. So if both parties of the discussion understand that what you mean by abortion is the non-spontaneous ending of pregnancy, then you mean a termination. But the problem is they're using that definition to include the medical procedure. So they're using a colloquial definition to try to regulate a medical procedure. And I'm going to illustrate why this is a problem with an example. So let's say you have a pro-lifer on the internet who's saying you should not be allowed to surgically end a pregnancy at any stage. Like, okay, well, that's a problem, right?
Right.
Because
Because you got a
what's a
43-week
C-section?
baby cooking in there. Yeah.
Yeah. It was
Yeah.
like you got a full-term fetus that we need to get out, and it has indications for a cesarean section, and the baby's probably going to live after that. Probably even there are plenty of parents that want an elective C-section. Those are very common now. So they might phrase it and they might take the scenario and they're not even thinking about this particular scenario. They're not necessarily thinking about the elective C-section, but they heard something about, oh, they're just trying to they're having a termination of pregnancy in the third trimester. Like, oh man, they're having a termination. That means they're having an abortion in the third trimester. They're killing a baby in the third trimester.
No, they're just
That's
getting
not
it
at
out of
all what
here.
is happening. So
Right.
so they're using the definition of abortion. If they're using it too broadly, they're trying to imply something that is happening that isn't actually happening.
Right.
And this is where we're getting into a lot of weeds with our policy making and with a lot of decision making on the part of pregnant people and their partners and everybody involved in their care. One of the terms that really grinds my gears along with this is, and we'll get into this too. I have a whole list from ACOG about poorly used terminology with regard to the abortion discussion. And one of them is the concept of a late term abortion, which, like, if you think about this and our gestational timeline, like, what is term? Like, term is beyond 37 weeks. So you're not having an abortion, number one, at 37 weeks, because it's beyond 20 weeks. So we're in the phase of a delivery, but you can have a termination and have a delivery at the same time. So if I were to have a third trimester termination, I'm going to, whether or not the fetus lives, I'm going to deliver that baby. That has to come out either by an induction or a cesarean section, one of those two ways. So people will throw out the term late term abortion and they'll show a picture of a full term fetus at about like 37 to 40 weeks
Right.
and say you're advocating for the killing of this baby. Well,
Right.
no,
No.
because what you're referring to, like, you're invoking the medical definition of late term.
Right.
However, you're using the political term for late term abortion, which refers to that period between 20 and 24 weeks gestation, which is a totally different conversation of ending a pregnancy at 20 weeks versus ending a pregnancy at 40 weeks.
Right.
So that's some kind of dishonest tactics that they'll take with that. And there is a lot of stickiness in this particular conversation because of that very sticky area of the 20 to 24 weeks of, like,
Right.
yes, you will likely have a fetus that doesn't survive if you
Right.
were to terminate at that stage. And there's a lot of discussion of, like, would people be comfortable knowing that that was the result, or what are the ethics of performing a termination and knowing that that's the result. And I think that's a valid thing to think about. However, where a lot of us already know that the conversation goes is ultimately the decision has to be up to the person
Right.
having the pregnancy.
Right.
And so kind of going into more of that side of the discussion, now that we've laid kind of the groundwork for the definitions, thinking about the philosophical discussions of pregnancy and what it entails, and why do people who don't know anything about pregnancy, why do they think that they get to weigh in on somebody else's medical care? It just doesn't really make sense. Let's think about a patient with, like, diabetes
Right.
or any literally any other medical condition. Like,
Literally any other one.
if you have a friend, or even, let's not even say your friend, there's somebody in the world out there, multiple people in the world right now that have diabetes. And let's say, I don't know, for whatever reason, you just don't like insulin. You think insulin's a terrible thing to give to people. You have no medical credentials. You know nothing about diabetes. You don't even know the people undergoing this treatment for diabetes. But if you decided to say, I think we should ban all access to insulin, and, like, if people reasonably ask you, okay, so why do you think that?
And
And you
people
say,
will
well,
die.
I don't like it. And you don't give a good medical reason for why you should ban insulin. Like, the reasonable question is to say, why are you making this decision?
Why do
Why do
you
you
care?
get to tell somebody, multiple somebodies, that you have no idea about
Yeah.
what medication they should be taking? That doesn't
Right.
seem to be your place in this conversation. In fact, maybe
Right.
you don't have any place in this conversation.
Right, right. I had kidney failure when I was 20 years old, but it kind of extended until when I was about 21. And when I think about the abortion debate, I think all the time about how I almost died when it first failed. And I think all the time about how they're about to help me, but what if somebody had come in and been like, "Hey, so they just passed a law that says we actually have to leave your infected kidney in there, and that we have to wait until it ruptures and then we can make a decision." Like, I'd have been like, "What are you like? What does this have to do with anyone else? I'm paying for this." And yet, for whatever reason, people think that they should have these thoughts and opinions on pregnancy and things like that that will never, they will never be pregnant. It will never impact them. Or if they were pregnant, they would get to make their own decision. If we made laws that allowed people to make their own decision, they could do whatever they want. It's like the gay marriage laws doesn't mean they have to get gay married. It just means people are allowed to if they want to. And it's just wild to me that it almost goes against most people's best interests, to be honest with you, when you really think about it.
Definitely.
It's just
And
odd.
I think that a lot of the avenues of discussion that we tend to go on, I think they're an okay start to have. I think it's definitely still valid and still worth it to engage in the conversations of um, bodily autonomy, of
Yeah.
saying like who should get to make decisions for themselves. Like, obviously, you should be able to make your own decisions.
Right.
And then, of course, it's still worth having the discussion of who are you going to prioritize in any situation,
Right.
um, and all that. I think those are okay discussions
Right.
to have. I think there's some more
Right.
layers we can add on to this discussion, because I tend to see this particular way the conversation goes down on the internet, and it ends up usually just being a shouting match between two people. One person says, "You shouldn't be killing babies. That's always wrong. Do you think it's ever okay to kill a person?" And then the other side will say, "Well, a fetus isn't a person, so we don't even need to go into this discussion." And
Like,
like,
why are we even talking about this?
you're technically right. Like, we're not
Right.
qualifying a fetus like as a person, but ultimately in this discussion, personhood does not matter. Personhood
Right.
is irrelevant to this conversation because, number one, like, this is about your right to control your risk of complications, and it's not necessarily about your right to have or avoid consequences of your pregnancy. This is,
Right.
you have a medical condition and you're presented with options
Right.
for management of said medical condition, and you should have the choice to decide how you're going to proceed in the medical care going on with your body. And everybody is going to
Right.
have very
Right.
different risks with their pregnancy and very different opinions about those risks of pregnancy. Um, but I think we need to focus on, like, why should we grant these rights to bodily autonomy other than just the fact that you have human rights? Because in all these discussion, we disagree on the human rights part. So it
Right.
seems to be a kind of a dead end discussion even in
Right.
there.
Right.
So
And
if everybody, I think everybody can be more on the same page if we say, let's stratify our risk and who gets to, like, exactly what is the risk? How do we determine this risk? How do we determine what interventions are necessary for this risk? And is there validity to trying to prevent this risk in the first place?
Right, right. And I do think that everyone should have someone other than them with the legal ability to make medical decisions. So, for
Mhm.
example, I'm married. One of the reasons it was so important for me to get married, even before we have our wedding, is because I wanted somebody to have medical power of attorney over me who lived with me on a daily basis, who knew everything about me. Because, if your parents are your medical power of attorney, they may not know what you've taken recently. They may not know what you've eaten or drank, but somebody who can say, this person takes this, eats this, is allergic to this, needs this. And like in moments like that, say I'm in the middle of a very dangerous delivery and maybe I'm not even conscious anymore.
Mhm.
They know what my decisions would be and what choices I would make. So I understand the need to have people who legally, whether they're your relative or somebody that you appoint, have that decision making skill. Because again, if we just leave everybody alone, that if you're unconscious, nobody can do anything and you're screwed. But I don't understand why only some medical procedures get intense legislation and
Mhm.
the others don't, right? Like it would make sense if abortion was legislated so heavily and so was everything else, and so was cancer and so was legit anything else. But it's just this I care about this fetus that doesn't exist yet, this theoretical fetus. It's like having a debate about theoretical cancer or a theoretical jaw problem or it doesn't make sense in any other context, but it's such a heavy and emotional topic in this context, and it seems to be going nowhere.
Right. And pregnancy, and I'll talk a bit more about kind of the earlier stages of pregnancy and where we get some sticky discussion regarding risk there. But going with the obvious risk of pregnancy, delivery is very dangerous.
Right.
Any kind of delivery is dangerous.
Right.
Cesarean section is dangerous. Vaginal birth is incredibly dangerous.
Yes.
And in fact, when we are counseling patients at the hospital on the labor and delivery service, we have a huge monologue that we go over with them about really anything that could happen during their time on the labor deck with us, because everything moves very, very quickly. And like you were saying, you don't know if something's going to happen. You don't know if you're going to be in a position to advocate for yourself later.
Right.
So we go step by step through everything that could happen and make sure that they are consenting and understanding about the things that are going to happen, so that they can make those decisions ahead of time.
Right.
Um, but it's very kind of scary talking to these patients about it, because they haven't heard a lot of these things before, because pregnancy is seen as this very easy thing in the media, especially how medicalized it has become, and it's done so out of necessity because it is incredibly dangerous. And you hear stories of people having home births with unregulated midwives, and especially there was a case recently in Nebraska regarding this.
Mm, yeah.
And I cringe at everything I hear about that case, because people that have never managed a pregnancy don't understand really like the reality of the things that happened. Like in that
Right.
particular case, it was a home VBAC footling breech delivery. And
No.
I have a lot of problems with all of those
Right.
things.
Right.
So like people that are having these discussions oftentimes don't understand those types of complications. And for example, there are examples of people that have had uterine ruptures. People have had bladder ruptures from C-sections. You have risk of postpartum hemorrhage is probably the most common cause of um, mortality in
It's wild.
the partum and postpartum period. Um, and I've seen people with multiple liters of blood loss just from delivery. And a lot of times people don't even know that they have a bleeding disorder. Some of them might not even have a bleeding disorder, and they'll still have hemorrhage for whatever reason. Things like shoulder dystocia, where you might have to take very extreme maneuvers to remove the fetus from the uterus. You have anytime you're doing an operative vaginal delivery, like with forceps, anytime you introduce something new into the uterus, you're increasing risk of infection and you're increasing risk of trauma. You are in in a vaginal delivery, especially as well. You can have severe laceration causing incontinence for the rest of your life. It is absolutely life changing, and can be very traumatic if you have a crash C-section where you're planning a vaginal delivery and then something happens. This baby that you've been planning on having for months now, you're probably very excited to welcome into your life, and now something just happened, um, just suddenly, and you're worried about survival now for both the parents and the baby, and you're going straight to the OR, and oftentimes nobody really knows how that's going to go, and it's absolutely terrifying, and it's traumatic for the
Right.
person involved. So, and especially if the fetus doesn't survive, in that case, it's even more traumatic. So thinking about just the risks associated with the delivery, and that's just if you make it all the way to that stage. And then taking into account as well things like if you were to have preeclampsia or eclampsia, or if you were to have some kind of
What does
intrauterine.
that mean? I know it's really
Yeah,
bad, but I don't actually know what that means.
yeah. So it's kind of a spectrum from gestational hypertension through preeclampsia, then eclampsia and HELP syndrome. These are all kind of along the same axis of conditions, and all of them relate to high blood pressure in pregnancy. It's super, super common and super, super dangerous because if you think about the placenta, it's, of course, it has a bunch of like spiraling arteries that go into the uterus that receive blood flow from the parent into the fetus. And if there are problems with the placenta, then baby's not getting oxygen,
Got
because
it.
that's the one way baby can get oxygen. So if the mom has hypertension or high blood pressure, it can kind of cause modification of these spiral arteries, can cause like some thickening of them, or if just the arteries themselves uh, kind of grew in a weird way, um, you can get these same complications as well. And you essentially cut off blood flow, and sometimes too could get a like the where the placenta just removes itself from the uterus, depending. Um,
And is that permanent? So, like, if you have that for one pregnancy, are you guaranteed to have it for the next pregnancy as
you're
well?
not guaranteed, but you're very high risk.
Got it.
And the complications that can come from this, um, like it's oftentimes judged based on the blood pressure itself and kind of the degree of severity based on blood pressure, but also signs of end organ damage. So that is a big thing.
Whoa.
As we are talking end organ damage. So that can include lung damage, such as pulmonary edema, so fluid in the lungs. It can cause kidney failure. It can cause liver failure. So, in fact, the kind of textbook
In
definition
the mom or
of
in the baby?
preeclampsia in the mom.
Wow. That's
So, kind
wild.
of the textbook definition of preeclampsia is high blood pressure and protein in the urine, which is kind of synonymous with kidney damage.
Right.
But we've kind of learned that you can also have other organs that get damaged. And that's also bad enough to where you would say, hey, baby needs to come out because this is problematic for everybody involved. Another thing that can happen is what leads into eclampsia itself, which is neurological damage, so brain damage from the whole condition.
And that's
And
for the
so
baby or for the mom?
that's for the mom. So that is
Wow.
marked by seizures. So you are
Oh,
preeclamptic. Um, there are certain parameters that will make you uh, without severe features or with severe features. So if you have high blood pressure without like high blood pressure and protein in the urine, but without like signs of other end organ damage, you are considered to have like preeclampsia without severe features. If you have other end organ damage like liver failure, heart failure, lung failure, um, all of that, if you have like low platelet function, so again, a function of the liver, but can cause you to have bleeding risk, that is severe features. And that is really dangerous. And then going the next step is once you have seizures, you are now in eclampsia. And that can lead to kind of permanent neurological damage.
and that's
So
just from your blood
that's
pressure.
from, yeah, that's from blood pressure and organ damage. So uh, it,
Interesting.
it's fairly common too. So um, and the way to manage this is by delivering the baby, and that's
Mm.
really it will resolve usually with
Really? It just
yeah,
goes away?
with delivering the baby. Yeah. So if you have pre-E without severe features, or even with severe features, kind of depending, you can usually um, deliver 37 weeks or later. So usually you'd still at least wait until term before inducing the delivery. But if you have eclampsia, so if you have seizures, the standard is to deliver at 34 weeks. So you are
Wow.
now preterm. You are now inducing a preterm gestation, and by definition, you are having a termination before term. So it's not an abortion, but it's still not a fully uncomplicated delivery. This is still very risky. Most people will not electively deliver anything earlier than 37, much less something like in very severe cases, like 36. But unless you have like risk of dying from eclampsia, then we will induce or do cesarean at 34. So
And would
that's
that be like a
significant enough.
premature baby, like
That
the ones
that
that
would be a
go in the
premature baby.
NICU? And
Yep.
interesting.
That's a yeah. Likelihood of survival at 34 weeks is still fairly rough.
Right.
Yeah, and some other complications as well, like risk of having DIC or disseminated intravascular coagulation, which is a simultaneously bleeding and clotting disorder where all of your platelets like start clotting in weird places, and because they're clotting, they are now used up and can't prevent bleeding in other places. So you have
Jeez.
clots, and then you also have bleeding, and that is something that can happen by being pregnant.
Wow.
It's not super likely, but it's common enough that we make a big deal out of it.
Yeah.
Um, Other things that can happen is if your water breaks too early, the fetus and the parent can get infections. So in those cases, you'd often, depending on the stage of gestation, you you have like a timeline for basically you have 18 hours or so to get baby out of there before you're really risking infection. So that's a case too where it's like if you have somebody whose membranes rupture at 20 weeks, 24 weeks, any of that, it's still technically viable, still technically beyond that point. This would be like kind of that weird gray area, but we would still kind of expectantly have to deliver at that point, because if you keep the baby in, you've got a lot of risk of infection. I think there's some procedures to like there's certain instances where you can do something like a cerclage where you essentially like sew the cervix shut for
Okay, so I've
certain
heard
things.
of those, and I've heard
Um
they're horrible, but I wasn't sure what that
yeah,
meant.
that's something that can be done occasionally, but everything kind of depends on the person's case and what's going on with them. Um, but you can see just throughout this whole process, there's a lot of complications,
Right.
and a lot of those complications, a lot of the medical reasons to terminate happen well beyond the point that somebody's having an elective abortion. So
Right.
these
Right.
are people who usually want to have the baby, so when we're referring to something like a late term abortion, even at that 20 to 24 week, oftentimes those are in people that want to keep the pregnancy and they
Right.
had to terminate because of some of these medical reasons. So,
Right. And that's
so
why it's like it's such a complicated set of I mean complications, problems, treatments, questions to be able to just put a Band-Aid
mhm,
law over all of it and not and, like, close their ears towards any kind of nuance or situational, like that woman in Texas who eventually had to leave Texas in order to get her medically induced abortion. She wanted the baby. She already
mhm.
had, I think, 2 or 3 kids, and she really wanted that child, but she was literally going to die if she tried to give birth to that child, and the child was also not going to survive. And so it's like, what do they want? Like, what is the point of making this woman who clearly wants to have more kids and probably will, although after this, if she can, who knows? Um, it's almost like you're punishing the people, like you said, who very likely wanted those kids but can't have them, or there's complications involved, and then to just say no, like that's considered an abortion if you help that person, and that's illegal.
And on top of that, you're punishing the physicians who are making these decisions
Yes.
because
Yep.
people don't think of the lack of time you have to make a decision like this and the
Right.
lack of certainty oftentimes when you are it's very hard to tell from the outside when somebody is having a uterine rupture.
Right.
um, you can make a guess. There are some clinical signs that can say, hey, I think maybe this is happening, but you're pulling the trigger at some point. And for any of these decisions, like whether it be an elective abortion, like before 20 weeks, or it be a termination afterwards, you're having to make this decision at some point.
Right.
And the big question here that a lot of OBs are asking is like kind of something that you said earlier on in the stream, is that how emergent is emergent enough to step in? Like when people say, yeah, I don't support elective abortion or elective termination, but I do support it in cases where it would prevent maternal mortality, or fetal mortality.
Right.
And like that's a great thing to think about. Um, However, like when you're immediately about to die, that's often too late to intervene, and now
Right.
you're going to have even more complications. So when do we step in? Like if
Right.
we know that somebody has certain complications that would predispose them to a very very complicated prenatal course and delivery, um when are we making the decision to intervene, and who gets to determine that decision to intervene? And I
Right.
think my perspective and everyone else's perspective is that it should be, ultimately the patient's decision of what decision to make, but with the guidance of somebody who understands the context and understands the situation and
Right.
has the credentials, to perform those interventions as
Right.
necessary. And if you think about it, if you are in an emergency, like let's say you're having a postpartum hemorrhage, or you're having some situation where maybe like you had a VBAC, uh, so a vaginal delivery before or after cesarean, so you're more likely to have a rupture at the incision site of your previous C-section. Um, let's say you were trying to do that and you had a uterine rupture. Um, would you rather have your doctor have the time to think through the case and what's going on and have time to prep you for surgery, prep the anesthesiologist for surgery, have everybody be like well fed and slept and like ready to do the procedure? Um, or would you rather it be a crash emergency? We have to go right now. I don't know when the last time I peed was. Anesthesia's running up from the OR downstairs trying to make it in time. We don't have any epidural place for whatever reason because mom wanted a natural birth, which is fine. But now we got to do general anesthesia, so she's going unconscious now. Um, do you think that the surgeon in that case is fully thinking through the nuance of the emergency case? Like not as much. Like there's a
Right.
point in the emergency, like there's a point in medical care in general where you lose the ability to like think holistically about the situation and you just rely on an algorithm. And that's why algorithms like CPR exist, because when you're under pressure, you have to do something and you have to do it now. So here's an easy mental shortcut in order to make the best decision in the worst case scenario.
Right. Also,
So
can we demonetize CPR videos on YouTube, by the way? Not everybody has time for a 30-second commercial. Like, that's
right,
a whole
right.
conversation. Can we just not do that?
Yeah,
That
yeah.
seems like an idiotic thing to happen. Anyway.
Yeah, well like so if you had kind of these two scenarios, like I mean you could make whatever decision you want, but like waiting for it to get to that emergency point before you're allowed to make that decision is therefore forcing somebody into a less safe situation.
Right?
When
Yes.
probably like if someone has pre-E and they could have delivered a bit earlier, and prevented things from progressing farther, they might have been a lot safer. And so a lot of this, what it comes down to, kind of like I alluded to at the beginning, is what is your risk? What risk are you willing to take for yourself? And then as a physician, what is your responsibility, or and what is the level of responsibility that you're taking for this person, which is usually pretty much all of it. Um, and are you comfortable like performing those procedures, like and advising somebody to have those done? Like, are you giving them
Yeah.
the best recommendations for that, with whatever situation? And somebody has to make the call somewhere. And let's have a what sounds like a very extreme example, but is actually it ends up being a very nuanced problem. So let's say there are a couple. I might do a couple examples because I can think
Sure.
of a couple good ones. So let's say you are a person with Marfan syndrome,
Hmm.
which is a connective tissue disorder that makes you very likely to have aortic dissections, which we actually know somebody in our community who has survived multiple aortic dissections
Jeez.
from Marfan's. Like, this is a very high likelihood of getting
Right.
aortic dissections.
Right.
Um, and having a pregnancy, let's say this person gets pregnant, um, not the person in our community because I don't believe they have a uterus, but somebody else who has Marfan's and has a uterus and is capable of getting pregnant gets pregnant. The likelihood of having, number one, the fetus compress onto the aorta, like because you just have your organ shifting around, um, you're going to have some distress there. But then additionally, uh, having the more abdominal pressure, you can have increased risk of aortic dissection, and
And is
especially if you
that
get
like
something like,
that's not a heart attack, is it?
oh no,
That's,
it's where your aorta just ruptures. It just tears itself. And it's very rapidly fatal.
oh my goodness.
So you could die. You could die like that with an aortic dissection. So
Wow.
if you are like, especially if you were to get gestational hypertension, like not even reaching the stages of like pre, etc., like any kind of hypertension can
Right.
increase your risk further. So we know that all this can make your risk of dying very, very high.
Wild.
And let's say you had to make this decision, like you have this pregnancy and you can decide, do I take the risk of carrying this pregnancy to term, knowing that it's going to be very dangerous and I could die? Or do I elect for an early termination or an abortion? Like, and that's not a decision that anybody can make for anybody else. That's a very complicated situation. And I think it's problematic if someone were to say that everybody in that situation has to carry to term, because how many lives are going to be lost based on that, especially people who
Right.
don't know that
Right.
individuals risk factors.
We
um
don't even mandate that everyone wear the same size clothing. So why on earth can we easily mandate that everyone's medical procedure should go the exact same way and follow the same rules? Like, we don't even mandate casual things. We don't even say nobody's allowed to have more than this many cups of coffee per day legally. Nobody's allowed to drive this long. We don't even say those things. We have recommendations. The only thing I can think of that we regulate for everybody is like smoking distance from a building, or like you can't smoke inside. And even then, like, some people do anyway. But it's just wild to me that it seems like such a good idea to make these generalized laws that seemingly harm more people than they even help. It's not even like, well, they help 50% of people, so we're going to go with it. They don't even seem to help 50% of people. They seem to harm pretty much everyone that they apply to, which sometimes kind of seems like the point a little bit.
yeah. And another example I like to use is, let's say you have a cancer patient, or even somebody who didn't know they have cancer, but they got pregnant and now they do have cancer, and they are like eligible to undergo either chemo or radiation therapy, which can be very problematic to a developing fetus. Um, so if you were in that situation where you had to decide, am I going to risk my own life in not receiving my cancer treatment? Or am I going to risk the fetus by opting for the cancer treatment? Like, which way do you swing on that? And I don't think anybody can make that decision for
Right.
anybody else. Um, and people can say like, but it's impacting another person. Well, that doesn't matter at this point. Like, either way, in this case, either way, somebody is going to be harmed. We don't know yet to what extent. We don't know exactly if this person with cancer is going to benefit from chemo. We don't know if chemos, even like if they don't get it, if they're going to die. We don't know any of that.
Hmm.
How, like you can't look in the future and know at all. You can't know. But you have to make some decision. And you might make what you think is the wrong decision when you look back on it later. But right now, some decision has to be made. And I think people don't understand the gravity of that decision making process. It's like I reference a lot the sword of Damocles, um, which like if we're talking about somebody who's the king, who's making a lot of decisions, but also having a lot of nice things and stuff, and people are jealous because they're like, why do you get to make all these decisions? Why do you get to do all this? And the person is sitting there with a knife hanging above their head by a thread, and at any point that can fall on them. And I think in this particular situation, especially with pregnancy, it's not like the knife isn't over me. Like, I mean, yeah, I have repercussions of like lawsuits, licensure issues, but the knife is over somebody else's head.
Right.
Like, and I have to give a recommendation and help make a decision for somebody else who has no idea really what's going on, but they have to make that decision about the knife over their head, and then you ultimately are responsible for that. If the knife falls on them,
Right.
that is my fault.
Right.
I have to help make the most reasonable decision possible, and sometimes that is, unfortunately, going to result in the delivery of a non-viable fetus. And I don't think that this is something like a lot of pro life people will think that we're callous and emotionless and have disregard for human life, and I think that's further like the furthest thing from the truth. I don't think anybody views abortion as a happy experience.
No,
Um,
no.
I think people view it as a necessary one, um, and the best decision that they can make with the worst scenario circumstances. Um, but it's yeah, I think there are countless examples I can give about why this decision should not be made by people who know nothing about this.
Right. Right. And it concerns me too that so many of these laws are being passed by people who don't have medical backgrounds. I
Mhm,
think if they are going to decide to start regulating things like abortion, terminating of pregnancies, criminalizing people who very likely just lost their pregnancies, the least they can do is elect medical professionals into office. People
mhm,
who are actual medical professionals, especially if they've worked in OB before. Um, and I don't think that's much to ask. And yet
mhm,
we're I feel like we are often made to feel foolish for being pro choice, and then we're made to feel foolish for trying to find middle ground. It's like if you're not pro life, then you're a murderer who just wants everybody to be able to abort fetuses, when in reality, you're like, no, I don't want women to die. I don't want anybody who's in the process of giving birth to die. That doesn't seem like a a pro-choice stance to have, right? Like I thought we all
right.
agreed that life is precious. So why are lives that haven't even technically begun yet more precious than the women on the table having to deliver them?
Right, and I think there are plenty of ways that we can meet in the middle. I think a lot of people don't want to, but because it addresses systemic things largely, and also addresses things that like are solutions we don't have yet, but are
Right.
potentials that people just
Um
don't want to look into because they're expensive.
Also,
Um,
I just want to apologize. Aunt Jared just pointed out apparently everybody can hear my dog snoring. I didn't know that. I'm
oh,
so sorry.
dang,
That's what if you can hear that, that's what that is. My dog is just snoring like a tractor. In case anybody thought
yeah.
it was like me farting or something like that.
But yeah, it's I don't even remember what we were talking about.
So we were just talking about like
Sorry.
the idea that having medical professionals
Oh
involved in
yeah.
the laws seems to be like such a far-fetched idea.
Oh yeah, yeah, meeting in the middle. Sorry, I ADHD is
Same.
super fun. So like kind of things that would like if we all have the end goal of wanting more people to survive, including the pregnant people and their fetuses, um, what we can do is we can help reduce systemic causes of poverty. We can increase access to healthcare. We can improve medical guidelines to to reduce prevalence of complications such as preeclampsia, everything that I already mentioned. We can try to work towards reducing those factors, which I think we're doing our best to kind of move that along. And then we can also look at, like, ultimately, I think the meat of this issue is the viability of the fetus. Like,
Right.
I think the thing that people care about on the pro-life side, ultimately, like, they care a lot about the fetal viability. And on our side, we care a lot about bodily autonomy. And I think
Right.
eventually there could be better ways to achieve both of these. And I think probably, like, the answer is looking into medical ways and, like, artificial ways to gestate outside of the uterus. Like, can we find some artificial way to, like, if we removed the fetus from the uterus, could we keep it viable? Could we gestate it to term or near term, which would not only keep those fetuses alive that were electively terminated, but would also improve viability for people with certain medical complications that might need to have an earlier delivery. Um, like, it would help out a lot of things. We're not there yet, and it's
Right.
a very expensive thing to do. Interestingly enough, I've confronted a few pro-life people that are somehow, like, really opposed to this idea because it's unnatural. And, like, okay, so then your issue in that case isn't
Right.
the life. The issue
Right.
is your view of what is natural and what isn't.
Right. Right.
That's a whole separate conversation. But I think
Right.
that there are places that we can go for the middle ground. But I think it's in that phase of, like, primarily for now, is like uh making that age of viability earlier. So, like, what can we do between that 20 and 24-week period to improve likelihood of survival? And what could we do even earlier than that, looking farther into the future? So, I think that might, at the end of the day, be a more productive discussion. Like, is if we educate people on, here's, like, not only the superficial picture, but here's the nuance, at least as much as people can understand without a medical background. Like, here's some of the nuance involved, and here's a way that we can move forward for all of us. And I think that's a, like, I'd agree. There's probably some problems with the way I'm looking at that, some problems that other people are too. And that's why I think, instead of having the discussion so centered around, is the gestation alive or not, focusing more on, where is the point that we disagree and where
Right.
can we move forward? And I think that is the point
Right.
of contention. Can we fulfill both sides of this at the same time?
Right.
And that's an answer I don't know. And that's why I think there needs to be a debate there. But if we have any questions or anything, I'm going to pull up some resources from ACOG to go over, just to kind of help further our ability to discuss and debunk some of the common myths related to abortion, and talk
Perfect.
about the language. But if we have any questions about, like, the whole meat and potatoes we already talked about.
Yeah. So, Mark was curious about your thoughts on liability in terms of being the person to make decisions for the patient. Do you ever worry, I guess, about being held accountable for making some of these decisions, or do you feel
Oh,
more so
always.
now? Yeah.
No, it's I mean, every medical decision you ever make has significant liability.
To what extent can you be protected versus to what extent can you be blamed and prosecuted?
Oh, I can be blamed for everything. Like, and that's
Really?
for any kind of medical care. Like, if there is something that I did or I recommended, um, I am accountable. And, like, kind of, there are other factors too that get looked into that determines kind of the severity of, like, your penalty for whatever it is. And I mean, sure, yeah, there are some things that aren't your fault that still end up saying it's your fault, because you, at the end of the day, are the captain of the ship. Like, you are the one that is supposed to be aware of all these things happening. And so that even includes mistakes that like your other staff make if they are
Yeah.
working with you. Like if your medical assistant is assisting in a procedure with you, like yeah, they're probably going to get in a little bit of trouble too, but that comes back on you too, because what could you have done to delegate better?
Yeah.
Did you choose the right person to assist you? Were
Yeah.
they qualified? Like, did you use proper guidelines? Like, is there anything at all that could have been your fault? Essentially, is what a lawsuit is for
Yeah.
malpractice. Is
And then if it goes
anything possible
right,
that could come back to you? Yeah,
right.
and then if it's
And
right,
then if
it's God.
we know
Yeah,
who did it. Yeah, exactly. Exactly.
yeah.
It's like what were you wearing when you did the procedure? Were you smiling? Did you have a good attitude? I mean, it could have been your fault. But it's interesting to me that oh man, there's so many ways I could go with that statement. I'll just look at the questions.
That's not the one I wanted to share. Hold on.
And then Mark
Uh,
also asked, "Do you think it will be overly long before pregnancy regularly occurs outside the body?"
I do think it'll be a while. I can't say how long, but it is very complicated. Yeah, so I don't necessarily think this will be in our lifetime, but maybe not too far after that. I mean,
Mm,
um, technology is improving very, very quickly. So I could very well be wrong, and I kind of hope I'm wrong on that. I'd love to see something like this happen. I just, with the pace of science as well, I don't know. Especially, I don't know how likely it is that this would be like legalized and like
right. Like humane.
supported as a standard of care in
Right.
our lifetime. Like, definitely not that.
Well, and then also you have to wonder, you probably have to monitor your first subject for at least one lifetime. Because, say, for
Yeah,
example, the pregnancy is successful, but every single test tube baby it ends up having sociopathy or something like that. You know what I mean? Like all the things that you have no idea they have
you just
until
don't know.
decades. Yeah. And
Mhm.
so I'm sure it would take decades or multiple lifetimes, probably, if I had to guess.
Yeah. So
Oh, I
this
did.
is
Sorry, I didn't realize you
a
shared a screen.
yeah. Just I've got a couple of these kind of nice little articles from the American College of Obstetrics and Gynecology. And this one's called Facts Are Important, Identifying and Combating Abortion Myths and Misinformation. So I can even share some of these links with Sydney to even put in the description of this so that
Yeah.
people can access them. But this addresses a lot of the common ways that we speak about abortion and and kind of the myths. So this first one is, how does abortion affect mental health? So their answer is that being denied a wanted abortion leads to more anxiety than receiving an abortion. So the arguments that you're going to have poor mental health outcomes from having an abortion are not supported by ACOG. Do people who have an abortion regret their decision later? And they're saying over 95% of women surveyed 5 years after having an abortion reported that it was the right decision for them. And then saying only you and your chosen healthcare professional can make that decision for you. And what are the risks of having an abortion? Abortion is a very safe medical procedure. It's one of the safest procedures you can undergo, and even compared to everything I discussed with a pretty
Birth.
normal delivery,
Yeah.
this is way safer than any of that. Only about 2% of women who undergo an abortion experience a complication associated, and they're usually minor and easily treatable. There's no scientific evidence or data to support that you can reverse a medication abortion. So you cannot do that. Does emergency contraception cause abortion? And they're saying no, emergency
Wait,
contraception does not cause
people
abortion.
there's people who think you can reverse a medical abortion?
Probably the same people that think that you can reimplant an ectopic pregnancy.
Ah, got it. I was like,
Yeah,
I never even considered that that was an option.
which again, so I mean, this is one here, the causing abortion with emergency contraception. Like if you're going to use that point with other people, you need to very clearly specify the definitions, because many people think that like if you're thinking that an abortion is the ending of the life of a gestation, if they determine like that life to start at conception, like yes, it prevents a pregnancy, which they might see as an abortion, but by our definition that we mentioned, an abortion refers to the ending of a pregnancy. And basically this does not fit the definition of abortion because the pregnancy did not exist. The fetus was not implanted into the uterus, which is the definition of pregnancy. So until you have implantation, it is not a pregnancy. So that's where ACOG is coming from here. So that's another definition we can throw in there. Just because there is a conception does not mean that there is a pregnancy. There has to be
Interesting.
implantation.
And I bet there's a lot of
Yeah.
people who would not like to hear that and would disagree.
Yeah. Oh, definitely. And that's why we can say something like an ectopic pregnancy is a pregnancy, because it's implanted. It's just
Right.
implanted somewhere else. And in fact, there are examples of ectopic pregnancies in the liver, which is an interesting thing. Which, how did it get there? If you ovulated and then you had conception
New fear unlocked.
in either in the tube or in the uterus, how did it get to the liver? I have a lot of questions, but
Right.
there are case studies of this, like they are published. These are things that can be found in journals.
And
So,
could you theoretically carry a pregnancy to term like that?
oh
Surely
no,
not.
it
I was
is
gonna
a
say,
it is an emergency. No, you need surgery. That is
yeah,
emergent surgery.
yeah. I knew it was
Um,
deadly for the parent. I just wasn't even sure if a fetus could survive like that. I didn't think so because there's no placenta or anything there, right?
uh, not at that stage. No,
Yeah.
not by the time that you remove it.
Oh,
Um, But something else, something I did not mention, and I regret that I didn't mention it already because it is one of the most mind blowing complications, if you will, of pregnancy, uh, which we actually had one like this in Gyn Clinic this week. Not my patient, but the OB residence patient. But there's something called a molar pregnancy, which have you heard of that before? And there's two different types of
I
molar pregnancy.
was gonna say I don't know, but it sounds horrible.
Yeah, so kind of the bottom line up front is that it is essentially a cancer pregnancy. Like it's not really viable. It is you're pregnant with a cancer baby. And how this happens is you have during the process of meiosis, you have the wrong number of chromosomes in there. So like and during fertilization as well. So if you have the wrong number of chromosomes like in the egg or in the sperm and then they meet, now you have like double or triple the chromosomes that you need. And this can cause essentially out of control cell growth. So when you'll see like the marker for pregnancy is beta HCG, and we usually will track that through pregnancy, and that's what triggers on a pregnancy test. But it's supposed to increase kind of at a moderate rate. But if it skyrockets like super high right away, that's kind of an indicator that a molar pregnancy is what's going on. And when you get an ultrasound, you often see it looks like it's described as like a cluster of grapes or like a snowstorm type picture because it's just an absolute mess.
And
And
it's in
one,
no way an actual fetus, right?
well, here's the kicker. Okay, so there's two types of these. There's one
I'm
type
googling it.
that there's no fetus present and it's just tumor. And so then you do a DNC and you remove it. The other type is a partial molar pregnancy where there is a tumor and there is either part of or like a whole fetus, like there's a fetus attached to this.
Oh,
And sometimes this is where it gets fun too. Sometimes those fetuses might have like a heartbeat or what people would call a heartbeat, which isn't actually a heartbeat, but what a lot of people would see as a heartbeat. And so, under a lot of abortion regulation, that would qualify as illegal in certain states with heartbeat laws if you were to have like a molar pregnancy that happened to have a heartbeat. But this is not viable. Like this
But
is a cancer pregnancy.
but
And
also like you can't like there's no like term with that, right? Like you can't there's at no point are you going to go into labor.
it's not gonna make it. Like you have to get it out because leaving it in as well significantly increases your likelihood of getting like uterine cancer. So like because it is cancer.
And it's just
Um
like a just kind of like a freak accident basically.
yeah, it's a cancer baby. Like as horrible as that sounds, like it is a cancer baby. So that's something wild that can happen that adds some more nuance to this equation. Like are you suggesting that people should have to keep that in there?
Right.
Well, like that's really stupid. Um
Yeah. Oh, I'm looking at pictures. That is
yeah.
rough.
And again,
Wow.
kind of with the last thing here, couple like talking about fertility after abortion, like it doesn't change your fertility, but then are you more likely to get cancer after an abortion? No, but if you have a cancer pregnancy, then you are more likely, not necessarily get breast cancer, but more likely to get like uterine cancer. And I mean anything that messes with hormones like can really increase risk of cancer. But pregnancy is a progesterone dominant system as opposed to estrogen, so less likely to get breast cancer like from either of these. But I guess that's a concern that a lot of people have.
Interesting. That's wild. I can't believe that would stay under like a heartbeat law. I mean, again, like say for example it does have what they would consider a heartbeat. What are you supposed to do? Because there's not like a 9-month cap on cancer. Like what are you just screwed and you just hope the heartbeat stops, or do you go to jail once the heartbeat stops? Like how does that even
I have no idea, and that's the problem with a lot of this regulation because it's made by unqualified people. Like they don't know what they don't know, and so
right.
they can't you can't make regulations on some of these like if you don't know. Like we can have as far as the medical side, we have standard practice patterns and we can say, hey, this wasn't appropriate or not appropriate decision to make, and like here's why. But like and even then there's some nuance, but at least people with some understanding of medicine can understand like, hey, this is our thought process, here's what we were thinking was going to happen, here's the risks that we thought were involved, all of that. But you have politicians that have no idea about any of this and they're like, oh yeah, it's just simple, just don't get pregnant or just don't have
But
an
also
abortion, just
make sure you fulfill your wifely duties at the same
yeah,
time. It's like don't
yeah,
get pregnant, keep your legs closed, but don't, but also do.
also
But
do. And also like, yeah, I mean, I guess you can have, we're not saying you can't have an abortion if you're dying. But then they have no idea what situations would cause them to be in that. And
right,
so then they don't include those scenarios in any exceptions.
right,
So it's like, okay, you've listed an exception that's not helpful because you didn't specify.
right,
And so it's just very sticky. So like, why do they even get to make this decision? And like, and that's something I like to put on people that I'm having these discussions with is like, okay, you are very passionate and very opinionated about this being the right decision in most cases. How much are you willing to bet on that decision? And not just monetarily. Are you willing to bet your career? Are you willing
right,
to bet like your reputation? Are you willing to bet someone else's life that you don't know? Are you willing to bet your spouse's life?
right,
What is at stake for you? And so like I question people that are making these decisions without any burden of responsibility for
right.
it because like
Without any stake.
you have no stake in this.
Right,
Like why should I take your opinion? Like if I'm giving a recommendation, I'm very cautious about what guidelines I'm using because it can come back to me. Like I made sure everything that I'm saying in this presentation is based on ACOG guidelines, like
right.
because if I have to go to bat and say, hey, like this is the right decision, or like this is a decision I made, or I'm recommending this decision, and someone says, no, that was the wrong decision. Why did you choose that? Like, well, because this is the guideline that is evidence based and established by experts. Like, I'm not an expert, and like I know that. Like, and I have a lot of people saying, well, how do you get to make this decision because you're an intern, you're family medicine, like, well, it's not my idea. This comes from people who did the research and who did the lit review and who have the years of experience. Like, this isn't my, I mean, it is my decision, but it's my decision based on expert guidance.
Right.
And so I'm more comfortable making that decision because of those reasons. But other people are just kind of going off of whatever they feel, and they don't actually know. And they also will never know if it's the right decision because they won't have to find out.
Right. And
So
also, I feel like you've also seen a lot of the effects from both sides of the coin. People who refuse certain things, people who are allowed certain things. I feel like you're coming from an area where you're like, trust me, I have seen what happens to people when they blank, when they do, when they don't, when they elect for this, when they aren't conscious enough to elect for this, when they wait too long. And so that should be a trusted opinion. But it seems like even you can be accused of having some kind of ulterior motive, which doesn't make a lot
right.
of sense.
Right. And there's like a healthy level of skepticism and there's a healthy level of questioning, but that's why this needs to be a joint decision.
Yeah, absolutely. And then Mark said, Dr. Ben, do you regularly consult others about decisions you make?
Oh yeah. Oh yeah. Almost always it's a share. I mean, like especially if it's something outside of my particular specialty, like there's almost always discussion with somebody more qualified.
Right.
And especially as an intern, there's always somebody more qualified having the discussion. So like if I was on the labor and delivery deck, of course, I'm not a surgeon, so I cannot perform C-sections. But anything complicated like this, I would at least, if there's not an OB on site, I would be on the phone with one. I would find a way to be on the phone with one.
Yeah.
But let's say, like, if you are the OB, you are the last line of defense here. They got to make that decision, and sure, they have colleagues that they can go to, and I'm sure that they go to their colleagues as well. But they have a lot fewer people that they can rely on, and there comes a point in any specialty where you have to make that final decision,
Right.
whether you're the ideal person to or not. And that's unfortunate, but like that's what happens a lot of the time.
I would trust you to do my C-section, Dr. Ben.
Please
I would
don't.
trust you.
Please don't.
You're
I'm
on the
not.
phone. You're
I'm
like, I
not
do what
credentialed.
first?
I can assist in the C-section, but I am not credentialed to do it. So
unless I have faith in you.
So yeah, we were talking the standard for C-section for a crash C-section is a minute or less to get the baby out.
That sounds like a game show to me. Sounds like a game show idea.
Yikes.
You're like, that's why you're not in charge.
I shared with you one more article.
I'm so sorry.
From
my mic is sitting in a way that it like hides that part of my screen.
Oh, no problem. Yeah, so this one is about the language we use to have these discussions. And I think this one is especially useful to everybody in the audience who chooses to engage on the internet or off the internet in any of this. So we already talked a little bit about late-term abortion, and they say it beautifully here that this phrase has no clinical or medical significance based on what we talked about earlier. So you do not have an abortion during that period. So what you can say is abortion later in pregnancy, or reference the weeks of gestation. For example, abortion at 14 weeks of gestation, because that clearly tells us what you mean and what we're talking about and what the context is for the situation. So that's probably a better way to phrase that. Things like chemical abortion has some bias. So saying medication abortion or surgical abortion, which medically, like, yeah, like it's, yeah, I mean, there's some debate here between specialties. Like, it could be considered a minor surgery in a lot of specialties. But yeah, I mean, procedure sounds a lot gentler. So I mean, I think that's fine. Although that one is a bit more debatable. Heartbeat pill, they have some good stuff here about the heartbeat pills. So It is clinically inaccurate to use the word heartbeat to describe the sound that can be heard on ultrasound in a very early pregnancy, because there are no chambers of the heart developed at early stage of pregnancy that the bills are used to target, so there's
Interesting.
no recognizable heartbeat. So, I mean, the things that you need to have a heartbeat, especially an audible heartbeat, are like chambers of a heart,
Yeah.
and valves, which you would not hear a heartbeat without valves because that's what makes the sound. But you could see movement of a heart when it has chambers, but when it doesn't have chambers, you don't have a heartbeat. But you do have early on electrical impulses, um, which that can also be the case in people that are brain dead. They
Right.
can have electrical impulses. That doesn't mean that they're alive. So,
Right.
changing the language to gestational age bands or identifying again by gestation.
How can they tell the difference between when they're listening? How can they tell the difference between the infant's heartbeat and the mom's heartbeat? How do they not hear both at the
Because of
same
the
time?
location that they're
Got it.
listening to.
So it's like a
Although
lot
you do,
louder.
yeah, because you're listening in the abdomen, so you're gonna hear the fetal heartbeat. We do monitor as it gets later on in the pregnancy. We monitor kind of both at the same time.
Yeah.
Um, yeah, the way we monitor uh, fetal activity during kind of the delivery period is pretty fascinating, and there are days of lectures I could go on about that, but it's super super cool. Um, yeah, and then kind of talking again about fetal heartbeat, and then getting into like the whole talks about dismemberments. So the procedure done for the time frame of after 12 to 15 weeks of gestation is a dilation and evacuation. So, dilation of the cervix and then removal of the products of conception, and often done using a vacuum and forceps, which is this is a very heated topic for a lot of people because they don't understand what is happening here. Um, People will call it dismemberment with the intention of being inflammatory,
Right.
but it is the removal of a non-viable gestation. And yeah, you can have some dysarticulation, but that's also a thing that like can happen with delivery, especially in things like a shoulder dystocia. You can have some things like that happen. So it's it's not an intended thing that happens with D&E. It just happens to be a circumstantial thing that happens during many D&Es. So that's kind of dishonest language if you see that being used, as well as I've heard the term abortionist before, which is we don't even really need to go into why that's
Right.
problematic.
Right.
Um, yeah, and then baby, yeah, it's calling it a baby. I sometimes will call it a baby, like as it gets closer to term, um, or if this is a desired gestation, I might refer to it more as a baby to like kind of humanize the process a bit more,
Right.
and somebody that is desiring a pregnancy. But scientifically, it is not a baby at that point. It's
Right.
an embryo or a fetus or a gestation, or products of conception if you're early on. Any of those terms are okay. Um, yeah, self-induced abortion, there's a lot of stigma with that. Um, Elective abortions, I mean, this term is still kind of okay. Yeah, abortion or induced abortion, which like it depends again on if you're using it colloquially or if you're using it medically. Like this is not
Right.
it's not a great medical term, but colloquially people still might need to use it just for ease of
They
understanding.
they try to make
Yeah.
it sound like a nose job or something if they're trying to make a
Yeah.
certain political point.
Hmm. Yep. And then partial birth abortion does not happen. That is also incoherent because you're not
Incoherent.
birthing the fetus part way. Like you're either removing the fetus or you're not removing it.
You're not removing like
Because
the half that you like.
yeah, it is like you're not leaving part of it in. And it's just very weird. Like, it was funny. I actually saw a comment on Twitter not too long ago that was hilarious. Or it was either on Twitter or on one of my YouTube comments, but it was hilariously incoherent about like, well, then what do you do if the abortion fails? And like, this is incoherent because like, if the abortion is the ending of the pregnancy, once the gestation is removed from the uterus, that is a successful abortion. So like a failed abortion would be like, what if the fetus is just left inside? Which like, yeah, that can happen where you leave behind products of conception, which is why they usually like do a thorough like washout essentially of the uterus to make sure they're getting all the pieces. But like, yeah, that would a failed abortion isn't that the gestation survived. That's not a
Right.
failed abortion. A failed abortion is you did not successfully remove the fetus. And I think from
Right.
anybody's point of view, that is problematic because you've now
Yes.
left a likely deceased fetus inside, and that is a significant risk for infection.
Well,
So
I do know that there are some companies that make videos and things that basically equate Quasimodo to, oh, that was an abortion that failed. You know, like this is what happens when you're an abortion
no.
that failed. You end up like basically an inhuman human, which one, it's like, how dare you say that about people who have
Mhm.
disabilities and things like that? But two,
Right.
that's not how that happened. That's not at all how that happened. Like people with
Yeah.
disabilities are not failed abortions.
Right, right. So just more ways that they use the terms incorrectly in order to smuggle in points. And so usually I'm not super pedantic about definitions as long as there's mutual understanding. But in the case of abortion, there's so much risk for smuggling in rhetoric by using the incorrect term, that I do get a bit more pedantic, or at least at bare minimum, if you're not going to adhere to the medical definitions, you at least need to establish clear, precise definitions of the colloquial usage.
Right.
So, like, if someone says abortion, it's reasonable to ask, what do you mean by that? What are the parameters that you are setting for an abortion? Because if you're meaning abortion to mean a non spontaneous ending of pregnancy at any stage, then you are also including elective cesarean section and elective or medically indicated induction of labor. So, like, make sure if you are using any definitions that you are clearly using them, clearly understanding them, and that you are holding the other person's argument like accountable for those definitions. Like if they set those definitions, make them stick to it, because that's how you get into the weeds with all this, is by letting them be loosey goosey with their definitions. And that's the same thing with the trans discussions, like not
Yes.
having clear and concise definitions, and therefore being able to imply things that are not actually happening.
Right,
Um,
right. And it makes it so much easier to be able to say, that's not what we're talking about right now. When people do that thing where they tangent off into, that's not what we're talking about. That's not what we're talking about. We're talking about this thing that we established up top, this thing. All this other stuff you're talking about is not what we're talking about. And I'm not even going to address that stuff because we said this is what we were talking about.
right, and like the people, one of my most favorite discussion points that people will use is um, the concept of an abortion minutes before birth, which is again incoherent, because if you were organically, naturally going to have a delivery like 5 minutes from now, um, having it 5 minutes earlier is birth.
I
That
guess I
is
was an aborted baby because I came a little bit
childbirth
early.
at term. That is called delivery at term. And a lot of people do that. So that is not an abortion, and it might be a termination if you were an induction, but like that says nothing about like ending of the life of a fetus, and it should not at all be used for policy because it just doesn't make any sense.
Right. Absolutely. I love how you call it incoherent. It's like the nicest insult I've ever heard. That is absolutely incoherent. I want to
Well,
say
it's
that
true.
to
It's
somebody
just,
once.
well, just like it doesn't make like it doesn't mean anything.
Like, you're
It
not
means
even calling them
nothing.
dumb. You're just like,
Yeah,
you are incoherent.
yeah.
That's
It's like they're trying to make policy on like points that don't mean anything. Like
right.
it's just you're just saying
Right.
words, and
You, sir, are just saying words.
that's for real what they're doing.
At
So it's
least
just
formulate them in a way that is not incoherent, sir.
right.
Um, and what I like about this presentation that you're doing is that it's helping people understand what it is both sides are talking about. It's important that we know what we're talking about, and it's important to help them understand what we are talking about. And it's also important, like you said, to at least be able to agree on terms so that you can say that literally does not happen. What you are describing does not happen. What you're describing might be this, like putting words to
Mhm.
otherwise inflammatory descriptions of scenarios that don't happen. That's not us being leftist and ignoring reality. It's us saying, I'm happy to have a discussion with you about real things that happen, but I don't want to waste my time discussing things that don't happen. And if you can prove something doesn't happen and someone still wants to argue about it, you recognize that they're not in it for the reality and for the truth. They're in it to argue.
Right. So that's definitely like all of that is why I wanted to have this conversation today, because I think it is really beneficial.
Yeah.
But that's kind of like all the kind of big points I wanted to hit on. So if there's any questions or anything, I know we're kind of getting
Yeah.
to the end, but if anybody has
Let's,
any burning questions or thoughts, love to
yeah,
hear
I
them.
marked some of the questions I see here. Um, Dr. Ben, do your emotions get in the way very often?
Like in what
I think
sense?
this was
Like,
submitted during the decision making
oh, decision making.
conversation. Mhm.
I mean, you're reasonably going to have emotion about anybody because like in any medical scenario because you're dealing with a human life and
Right.
um I try not to make decisions based on like unfounded emotion or like emotion that's going to compromise care because it definitely can. And definitely if you have even more empathy for a person, sometimes you do a worse job because you don't want to inconvenience somebody or you don't want to put them through more things that might not be necessary and then you miss
Right.
stuff. So it's important to not let it get to that point, but it's very important to maintain a sense of humanity in every area of medicine. And in fact, my med school now, when I took the class, it was an elective and it was a great elective, but they now require for everybody to take a humanity in medicine course, which talks about um, like primarily with regard to marginalized communities and their experience with medicine or certain areas of medicine that provoke a bit more of like humanitarian discussion. And I think losing emotion entirely is the wrong move because you
Right.
need to view people as human. You need to be able to evaluate their situation and think about the difficulties that they're going through. And if you're purely objective all the time, you can miss that. And furthermore, you can lose the trust of the people you're caring for. So I think that like yes, there are points when emotion can get in the way, and you just need to be aware of um, am I capable of performing my duties to the full extent that I need to? And if yes, then it's probably okay to proceed. But if you're getting to a point where it's too much emotion, then like, yeah, okay, maybe it's time to defer to somebody else and let them take over. Um, but I think that there's a healthy level of emotion to be had. So I think for everybody, kind of that balance is a little bit different. But
Yeah.
I can say that there have been times when it has gotten in the way. But hopefully it doesn't get in the way so much. And that's just something that everybody
Yeah.
works on.
I
So,
feel like at the point where you never have any emotion whatsoever, that's when you should be concerned. When you're like, I
right.
haven't felt in a while. I haven't felt feelings in a minute for people. Um,
Yeah.
well, Dr. Ben, this has been super informative. I'm going to grab that link from you whenever you have a second, if you email it or Facebook it or anything like that, and I can add it to the description box because I think it's a really important discussion. Um, and I also think it's important that we focus on having these conversations as opposed to just focusing on, I think, more unrealistic goals, like how are we going to beat these guys, as opposed to what we can realistically do, which is have conversations and teach people and inform ourselves. And I think informing ourselves is the most important aspect. Um, but yeah, thank you so much for your time and your research. I really appreciate all the work that you put into this. This was very thorough and well thought out. And I really learned a lot. Some things I wish I could unsee, some things that are important to know.
Yeah, thanks for having me. It's been great. And I look forward to seeing the rest of what Skeptic University has to offer this week.
Yeah. Speaking of which, folks, Skeptic University is still happening in case you didn't know, even though you're here. So stick around tonight and tomorrow and Friday and Saturday because I'll be here all that time and I don't want to be alone. Bye.